Good to see everyone again. We thought we'd continue on with talking about very, very common topics. Now we're going to take a look at insomnia over the next hour. Talk about a little bit about the different types of insomnia and potential treatment options. So, what exactly is insomnia? It's any difficulty or inability to initiate or maintain sleep that causes an issue with either some sort of impairment or is distressing to the individual. And it turns out with, at first you might think about it and think, well, insomnia, if they can't sleep at night, they're going to be sleepy during the day. And there are certain scenarios where you might experience that, but in general, as a group, you're talking about a more hyper-alert, hyper-arousal type state that exists in those individuals. So typically, daytime sleepiness is not a prominent complaint amongst insomniacs. They oftentimes will indicate that they're fatigued, but not necessarily sleepy. So that's an important differentiating point when you're taking a history from someone who reports insomnia. You want to separate out, are you actually falling asleep or feeling like you need to drift off to sleep? Or is it merely that you don't have the energy? You think, gosh, I need to get up and do this, or I need to do that, but I just don't have the energy to do that. You do see it more in females. Certainly you see it a lot in both sexes, but more in females and more commonly in older adults. Again, very common condition. About 1/3 of all adults will experience insomnia once a month, okay, or more. And about 10% of adults have chronic insomnia. By definition, the more episodic or short-term insomnia is less than 3 weeks duration. The more chronic form is 3 weeks, 3 or 4 weeks or longer. And that exists in that 10 to 15%, but the short term that goes even longer, you can see in up to 1/4 to 1/3 of individuals, okay, of adults. And once it's longer than 3 months, then that's really when you're thinking of it as an insomnia disorder for sure. But in general, you're looking for them to experience insomnia at least 3 nights or more per week. And it can be quite transient. In fact, I mean, probably almost all of us have had some transient insomnia for whatever reason. Maybe related to something else that's going on, pain, a particular stressful event, those kind of things. But it's quite far-reaching in terms of its effects. Insomnia is not just that you don't sleep well, you don't feel restored from your sleep, those kinds of things. It can affect really many, many different aspects. It leads to a lot of irritability. Individuals who have insomnia tend to have more interpersonal conflicts, okay? Both personal and professional in the workplace setting. It exacerbates or makes worse a lot of other conditions, both psychiatric and physical in terms of cardiovascular conditions, other metabolic disorders, and so forth. A lot of neurological disorders, headache, so forth. So with the sort of hyper-arousal, hyper-alert state that exists, how does that manifest? How do you see that? So individuals who are experiencing insomnia tend to have a higher heart rate, a higher body temperature, and some people can even notice that very quickly. Even I noticed that if I've had a night where I've had to be up all night for whatever reason, the next day it may not feel quite like a fever per se, but it can feel close. You can tell, oh, I can tell my body temperature is higher, you know, that sensation that you get. And some people can sense that better than others. They also have a higher degree of kind of baseline muscle tension, okay? And certainly those kind of things can feed back into it. If you're tense when lying in bed and the muscles are tense, it's more difficult to relax. It's more difficult to relax, it's more difficult to fall asleep. I remember one time years ago, I don't remember what was going on, but there was something, that was obviously preoccupying my mind, and I was thinking about it, and I thought, gosh, I'm having trouble falling asleep. And then I realized, oh yes, my forehead is actually scrunched. So I'm probably not going to go to sleep like that. So I kind of forced myself to relax my muscles, and it did certainly help. But, and these kind of things, you tend to think about, well, the people who have insomnia, they have it all the time. Not necessarily. I mean, really, these kind of things affect the vast majority of us at some point in time, either temporarily or sometimes it can last for a period of time and then go away. But very common scenario. And as part of that sort of hyperarousal state, you tend to have a very active mind, thinking about things, ruminating about things. And, it can be anything really. There's definitely more worrying. You see that in a lot of individuals. But sometimes it's not even that. Sometimes it's your classic planner. So sometimes people think about, gosh, I need to do this in 2 days. I'm not going to remember to do that. And now I'm in bed and I can't write it down. So I've got to think about that and get that in my mind, those kind of things. But we'll talk more about that in a few minutes too. And when you do perform EEGs on individuals with insomnia, they tend to have more beta activity. That's that really fast activity, on the EEG waveforms. Does anybody know the classic medication group that can increase beta activity? Also, benzodiazepines can potentially do that, so that's a possibility. In terms of your sleep drive, classically we've kind of thought about it in terms of two main things, and they've been referred to as process S and process C. Process S is really a buildup of intracellular adenosine, we think, and that's just our normal homeostatic drive for sleep. Because if you look at adenosine levels, they climb throughout the day, and then at night you go to sleep and they fall. And then they start down at the lowest point in the morning when you wake up, and then they rise again throughout the day. And it's interesting because how does caffeine work? Caffeine works at the adenosine receptors. So we think that's how it primarily has its effect on boosting wake, is by working on that. So that's certainly one factor. Another is, of course, that internal clock, the suprachiasmatic nucleus. And we've referred to that as process C. So it's kind of both of those together that go into increasing our sleep drive. And certainly there are a lot of things that can interfere with that. Like with the suprachiasmatic nucleus, there may not be necessarily anything wrong with it, but there are things that we can do, that lead to circadian rhythm disorders and certainly lead to insomnia as a component of another entity. So when you're talking about insomnia, it's very, very important, more than important, it's critical really, to adequately assess what's taking place. You can't, it's not all the same. There are many, many things that can lead to this, many, many things that can contribute. So that's why you really want to know the full history about someone's sleep. Very important to know, what time do you go to bed? What time do you get up in the morning? Do you take naps? If you take naps, how long do the naps last? How frequently do you take those naps? Okay? So all that's very important, because napping will decrease that homeostatic drive. Okay? That will decrease that adenosine. So that's why, sometimes people will take a 2 or 3 hour nap, and then they realize, oh gosh, I'm in trouble tonight because I'm not going to go to sleep for hours. And it can be disproportionate. Sometimes you may take a 20-minute or 30-minute nap, and especially if it's too late in the day, then that may keep you up for hours. It's not a one-to-one necessarily where, if you have slept for 30 minutes, then you're going to miss 30 minutes of sleep. It can certainly be disproportionate. You also want to look at, okay, when did this start? Is it Has it just been in the past few nights, past few weeks? Has it been going on for years and years? And is there anything associated with that? Does it, like with the RLS medication we were talking about earlier that can lead to insomnia, you want to know, did you start on a medication before this happened? Was there a particular life stressor or event or change that led to it? You want to get a sense of how it impacts the individual. So, is this causing impairment at work or at school with your job performance? Is it causing irritability with other individuals, leading to arguments? Those kind of things. It can really help you in terms of treatment and determining, kind of which direction and course you're going to take things in. You want to ask about the sleep environment. Things like temperature, light, noise, bed partner. If a bed partner is a really loud snorer and need treatment for sleep apnea, that can cause insomnia for you. That's why this is such a huge umbrella. Sleep hygiene matters. Substances potentially that you might either use or be exposed to, or activities certainly. You want to ask about what have you tried, and be very specific. As far as medications go, what did you take, what dosage, for how long. That's the other thing too, is I see a lot of people with insomnia where they say, oh, I tried medication X, didn't help at all. And then you say, well, how long did you take it? How many nights, how many weeks? They say, well, I tried it 3 nights. That's not going to be enough. Okay, that's not enough of a trial to know. And then, of course, always as part of a comprehensive sleep evaluation, you screen for everything else. Because, how many people have you seen who say, I lie down at night and it's torture. I can't go to sleep. I can't stay asleep. I wake up, I have to go to the bathroom multiple times at night. Well, even that's multiple things. It can be something leading to the need to get up to go urinate frequently, or it can be untreated sleep apnea that's triggering episodes of nocturia, right? So that's why it's so important to definitely delve deep into all of that and get all of those features fleshed out in terms of what's taking place with someone's sleep. There are many different types of insomnia. We'll talk a little bit more about these, and they're not mutually exclusive. Certainly, you can get a lot of these in association with one another. Okay, in fact that's more common than not. Okay, and that can be anything from sleep hygiene to the psychophysiologic features to what we call paradoxical insomnia. It can be lifelong, idiopathic. It can be part of an adjustment disorder, those kind of things. And certainly medications and other medical conditions can lead to insomnia. Sleep hygiene, I think, is it's unfortunate, the naming of that, because I never tell someone, I think there's a problem with your sleep hygiene, because instantly they're going to put their guard up or say, well, I brush my teeth every night. What are you talking about? I don't like the term sleep hygiene. I just say, well, I'm afraid there's some activities that you're engaging in that are working against you in terms of getting good sleep, because that's really what this boils down to, even in terms of talking about schedules or substances. Part of that is having a very irregular sleep schedule. Okay, can be, and that's extraordinarily common. If you don't have a fairly consistent bedtime, and if on the weekends you don't keep it fairly consistent, doesn't mean you have to go at exactly the same time, but in general, as a rule of thumb, I like it if individuals don't vary their bedtime by more than an hour or so on the weekends. They tend to have a much more stable sleep pattern. But you can imagine, it's not hard to think of examples about this. Think about your classic, especially teenage children. They go to bed at a regular time during the week and wake up fairly early to go to school, and then on Friday night and Saturday night they stay up till 2 or 3. Well, guess what? On Monday they're sleepy, and that's because Sunday night they're more in that pattern of Friday and Saturday night than they are during the weeknights. So it's very difficult to go from go to bed at 2 and wake up at 10 to all of a sudden, lie down at 10 and go to sleep, because we're getting you up at 5:30 or 6 a.m. Very difficult. But maintaining that regularity is really huge in terms of having a significant impact. And you almost have to have that kind of before you can start addressing the others, because if you don't have that, if you're not getting an adequate amount of sleep, hands down, by far the most common cause of excessive daytime sleepiness is insufficient sleep, right? So people who just don't get enough. And so you have to have those consistent schedules. The napping, it's really best if someone's dealing with insomnia, if they can really significantly limit their napping, because if you nap a lot, you're really significantly decreasing that intrinsic sleep drive, okay? And it doesn't even have to be late. It can be early on in the day, or fairly early on, but especially, of course, if you do nap close to bedtime or in the second half of the day. What I tell people is, if you feel like you need to nap, then try and limit that to no more than 15, 20 minutes at the longest, and certainly try to not do that for several hours before bedtime. Ideally even 7 or 8 hours before bedtime if possible. And then also, it's not just that. Some people spend an inordinate amount of time in bed, okay? So some people say, well, I can't sleep. I just lie there in bed. But they may go to bed at 7 p.m. and lie there and then eventually fall asleep at 10 or 11 and not get out of bed until 9 or 10 a.m. the next morning. Well, that's a very counterproductive pattern to establish, because, you're probably not going to need 12 hours of sleep every night. So you're going to perceive that as insomnia. So, you're lying in bed, and then on a subconscious level, you're making all kinds of associations. Then you're making an association with, I'm lying in bed, that's time to read, to worry, to watch television, to fill out my crossword puzzle, all those kinds of associations, things you don't want to associate with being in bed. You really want to associate that with sleep primarily. Certainly, there are a lot of different substances we can expose ourselves to that can significantly impact sleep. I mentioned caffeine earlier. And caffeine's another one of those, very variable from person to person. It's like I mentioned in the other talk, some people can take caffeine in drinks all throughout the day and not have a substantial effect. Some people, can have coffee at midday and say, oh, I just ruined my night, and so it's quite significant. Depending on the individual. Nicotine can interfere with sleep, so individuals who smoke, especially if they smoke close to bedtime, or if they get up during the night and go smoke, guess what? That's making things a lot worse. They're definitely contributing to wakefulness when they try to return to sleep. Alcohol is kind of interesting, because you'll talk with some people and they say, but alcohol puts me out. If I drink alcohol, I'm asleep. Well, the thing is, for most people, the tendency is for alcohol to help facilitate sleep onset, but the net result of it is decreased sleep because it increases wakefulness during the night. Interrupts sleep, then you're awake for longer periods. So the net result of alcohol is decreased sleep, actually. And again, it can be any behavior that you engage in that works against you in terms of sleep, whereas timing it a bit better may be may facilitate better sleep for most individuals. One thing I always talk about, and it's one thing that a lot of people do, a lot of people, immediately before you go to bed, what's the last thing you do? Brush your teeth, right? Well, you may not think about it, but if you're sitting on your sofa or recliner and you feel like, whew, starting to get sleepy, and then what do? You walk up and you turn on the sink and you're doing this. That's very alerting, actually. That's a pretty significant muscle activity, right? And I mean, I'm not saying that you brush your teeth and you stay awake all night, but that if you can time that a bit earlier, then once you start noticing that sleepiness, then you can go to bed and fall asleep easier generally than that is kind of alerting to a lot of individuals. I also tell people, if they're interested in losing weight, it's a very good weight loss thing to do. If you eat your supper or dinner, and then just a few minutes after that, if you go brush your teeth, well, toothpaste typically ruins the taste of most things, right? So you're far less likely to pick up little things and snack on it after that if you've already brushed your teeth. And plus, psychologically, if you've done that, then you're more apt to think, oh, I've already brushed my teeth, I don't want to mess that up. So you're less likely to eat. So it really can help. But it's not just that, it's other muscle activity or exercise. So, if you get on the treadmill and you do 20 or 30 minutes on that at 9:30, guess what? That can keep you awake longer. So it really is ideal, like with exercise, if you can allow for 4 or 5 hours, if possible, before bedtime, in terms of a separation there. And I realize, a lot of these things that we as physicians and providers recommend are kind of impossible. We create a scenario where you don't really have to work, or you don't have to pick up kids and things like that. I realize for a lot of these kind of things, you're fitting it in when you can, if you can get to it. But in general, if you can separate that by several hours with the exercise, that can really be quite helpful. A lot of us, especially in the past 10, 15 years with smartphones, it's very easy to go to bed and then, oh, that's a great time to check email. Or, oh, I need to buy a gift for so-and-so's birthday next week. So you get on and do a quick search for those kind of things. Well, it turns out that is enough light. It's not just watching television or having the lamps or overhead light on. The light from those screens are enough to send a message. We have a tract. We're hardwired. It's called the retinohypothalamic tract. And when that light hits the back of the eye, the retina, it has a direct input to our hypothalamus saying, it's daytime, you should be awake. So that facilitates turning on wake neurons and inhibiting sleep neurons. We really are truly hardwired to respond to when the sun comes up, we wake up, and when the sun goes down, we go to sleep. We've altered that dramatically with artificial lighting, obviously, but it's amazing the effects that you can get from looking at those little screens even. Some people, it's a real challenge. Their bed partner likes to leave a television on in the bedroom, so that can work against you in terms of noise and lights. And let's face it, a lot of programming now involves flashing lights and loud sounds and explosions and all this sort of thing, which also can have an impact. Like if you're just watching television in another room before you go to bed, it's one thing to watch kind of these movies where cars are exploding and flipping over one another and things like that a lot of our movies have in them now, versus a quiet episode of Perry Mason or something like that. Then that is very activating too, just the content above and beyond the lights. So that's why it really is ideal if for the last hour or so, at least 45 minutes, if you turn off the bright overhead lights, just turn on lamp level type lighting. Ideally turn the TV off if you have that on, and kind of read more lightweight kind of material, maybe not something where you think, oh gosh, I just finished that chapter, now I have to know what happens in the next one. So, you know, all those things combined definitely can play a very, very significant factor. So, I mentioned psychophysiologic insomnia. This is incredibly common. Almost all of us have some features of this, or you know, more dramatic examples of this, at least from time to time. And this is simply where you have a very active mind lying in bed. And in modern times, we stay under such a constant sensory stimulus barrage, whether it's, you know, you're talking with everyone at work or your family before you go to work, then you come in and, you know, you're doing whatever, you're helping your kids with homework, or you're, you know, talking with others or watching television, those kind of things. You really don't have kind of quiet reflective time, which is normally when we process things. So then what's the first quiet time you have all day? When you lie down in bed, right? So that's when you lie down and it's like, oh, okay. And then unfortunately, that's when worries can pop into your mind. Then you have to think, oh gosh, I've got to go here and pay this bill tomorrow, or got to pick up so-and-so tomorrow. You know, those kinds of things. So that's why I tell people one thing that can be very, very helpful is, you know, really kind of minimizing television time throughout the day, but especially in the evenings. But certainly trying to set aside 10 or 15 minutes where, and not right before bed, but more like, you know, 7:30 maybe, something like that, where you're in a quiet room, there's no television, no radio, no cell phone that you're tempted to look at. And for some people it's helpful to kind of have a pad of paper and a pen so that you can make notes. You know, you can say, oh yes, tomorrow I have to do this, or, you know, or by this Friday I need to do that. And you write that down. It doesn't mean those kind of thoughts aren't going to pop back into your mind at night when you lie down. They will, but you're far more apt to think, well, I've kind of reconciled that as much as I can for today. Okay? Because you already, you feel like you've processed it. You know, you've worked through it as much as you can. Very helpful thing to do. And one thing too, because with psychophysiologic insomnia, you know, these kind of active mind kind of thoughts, you know, it's still more of a hyper-arousal kind of state. They tend to watch the clock. That's why it's very helpful to turn that clock around backward, and then you look at it and think, oh, now it's 15 minutes later. That's 15 more minutes I've lost. What does that do? That creates angst. So then you're awake longer. So then it's another 15 minutes or 30 minutes, and then you think, gosh, there's another amount of time lost. So that really just serves to keep you awake. So that's why I really do recommend turn that clock around, because what does it matter what time it is, right? If you have an alarm set to go off to wake you up when you need to be awake, you don't really need to know what time it is during the night. So that can be a very helpful thing. And what I like to talk about too is relaxation techniques. And these can be very, very helpful because of those kind of situations like I was talking about earlier, kind of with a tensed forehead. You know, it's very difficult to fall asleep during those times. Some of the things that I like to begin with in terms of talking with people who have psychophysiologic insomnia is start off with taking 2 or 3 very deep breaths and slowly exhale, kind of really drag out, getting that breath out. And then after you do that, I like for them to engage in something called progressive muscle relaxation, okay? And that's where you can start off either up top or down bottom. Say if you start off with your feet and you tense them for 3 or 4 seconds. Not just passively move, but where you really feel the muscle stretch, okay? And then you relax them, neutral position for 3 or 4 seconds. And then you go in the opposite direction. You flex them up for 3 or 4 seconds. Then relax them for 3 or 4 seconds. And then you just progress your way up all the different major muscle groups. okay? And not forgetting things like, your back, upper back, stomach, chest, arms out to the side, and any joint that'll bend in both directions. Don't forget to do both directions. Spread the fingers wide apart. Do the neck. Do your head forward and backward. Tense your forehead. All those kind of things. And don't rush it. With every time when you tense that muscle group, keep it tense for 3 or 4 seconds, and then relax for a full 3 or 4 seconds. Okay? And then oftentimes when they get through with that, then what I recommend is doing a couple more of those breathing exercises. Take the deep breath in and exhale very slowly for 2 or 3 breaths. And if you do that on a consistent basis, it really can be quite dramatic in terms of the benefit and effect. The thing is, you really have to, you can't just do it once and, you can't do that one night and it fix your insomnia. That's got to be a learned pattern behavior where you do that. And if you do wake up during the night, yes, you can do that again, to help you relax. Or if you, say you don't have trouble falling asleep, but you just wake up in the early morning hours, which is a common feature of depression. Okay? Depression commonly causes that eyes fly wide open at 3 or 4 a.m. and then the first thing in your mind is a very negative thought, and that's in terms of worry primarily, those kind of things. So you can do this then. It's very distracting from those kind of things and very relaxing. So can be very, very helpful. Paradoxical insomnia is another one that I'm not crazy about the name of it because it doesn't quite make sense if you just say that. I like the old term for it, sleep state misperception, much better. And this is absolutely something that you see sometimes, and that's where people feel that they're not sleeping nearly as much as they actually are. So there's that misperception of how much sleep they're getting. And it can be dramatic. A lot of times with individuals who are experiencing this, you can do the sleep study, and then their sleep efficiency is 95%. And then you can ask them, how much did you sleep? And they say, oh, yeah, it took me hours to fall asleep. And then you can show them, and point this out. And so far, by far, the vast majority of people say, oh, gosh, I didn't realize it was probably an issue with how I'm perceiving how much I'm sleeping. So a lot of times, just that insight, when you point that out and show that to them, then they realize, oh, well, maybe I don't quite have the issue that I thought I did. So I routinely see, when I do see this, individuals report a lot of improvement once they realize what's taking place. So the treatment for that really is cognitive therapy, kind of addressing those mistaken thoughts. Adjustment insomnia usually is fairly easy to identify when you take an adequate history, and that's where there's been some event, some major life event, some big change, some stressor. It can be a lot of different things. It can be their the loss of a loved one. It can be a move. It can be a job change. Those kinds of things. And by definition, it's within 3 months, really, of the event. If it's further out than that, you have to question if it truly is that as the cause. Usually it's short term. It's typically less than 3 months in duration. Okay, that's separate from the onset. We're talking about just how long it lasts. And then in terms of the course that it takes, you kind of go really in one or two different directions. Either resolution, where it's no longer an issue, and they have managed to cope with it and deal with whatever the circumstance changes are, or it evolves and develops into a more chronic insomnia pattern. Sometimes they can pick up behaviors that are not conducive to good sleep while they're experiencing the more short-term adjustment insomnia. But again, the treatment for that is more cognitive therapy, bringing awareness to, this is normal, what you're experiencing, in terms of having either a grief reaction or anxiety about a major life change or circumstance change. Idiopathic insomnia is the term we use for the individuals who really have kind of a lifelong, dating all the way back to childhood pattern of insomnia. We're not absolutely certain as to what causes this. It's speculated that there may be some alteration in some manner of their sleep-inducing or wake-promoting systems. We need to research this more, basically. You don't see a lot of it, but definitely you can certainly see this. No particular pathology has been identified as yet, and we haven't found any kind of particular genetic foci or markers that put you at risk for that. And there's no precipitating factor or event that leads to this. They say, no, it's the way I've always been. And that can be very difficult to treat. It really can. But certainly, one thing too I should say, with all forms of insomnia, and I tell everyone this when they're experiencing this, there's typically not one magic bullet in terms of treatment. Okay? You really, with insomnia, you want to come at it from all sides and aspects. Okay? So if you have sleep apnea, you want to treat that. If you've got an irregular sleep-wake schedule, you definitely want to regularize that sleep schedule and address that. If you've got other conditions leading to it, restless legs or things like that, if there are medications that are contributing to it, if there are environmental circumstances that may be playing a part, so you really want to come at it from all directions. Very, very important. Behavioral insomnia of childhood is definitely something that most of us have seen at some point in time, whether or not it's in your own children, but you have certainly heard about it in friends or family members. And it really kind of comes as two main types, or kind of a mixture of the two. The sleep onset association type is there's something that they've associated with sleep onset that then they feel that they need. And that can be, mom or dad sitting next to the bed and holding their arm or hand, or with their hand on their back, or things like that. Or they need this certain teddy bear, to sleep, or, they are resistant to try to sleep if they don't have that, those kind of things. Or it can be, oh no, you have to rock me to sleep before I can go to bed. And that can be quite varied. The limit setting type, and you see this not only in young children certainly, but now more and more with teenagers having smartphones, the sort of stalling behaviors. 5 more minutes. No, please. Everyone else has responded to friend so-and-so. I need to too, or they'll think I'm ignoring them, or those kind of things where they're bargaining for more time to stay awake, essentially. In little kids, it can be, no, thanks for reading me the bedtime story, but can you do one more? And then one more turns into, oh, well, how about another short story? How about, that sort of thing. So, and the treatment for that really is kind of, just the parents establishing parameters and saying, no, it's only one, or, no, when it's time to go to bed, it's time to go to bed. Can't stay up 15 extra minutes playing video games or things like that. So in terms of all of this, in addition to medication, there are a lot of things we do in terms of cognitive behavioral therapy, and we'll talk a little bit more in terms of some specifics about those. So cognitive behavioral therapy, the cognitive aspect is trying to address those sort of beliefs and expectations that are working against them. They're dysfunctional, they're counterproductive. The behavioral aspect can be things like, associations with the bed and the bedroom, or restricting the amount of time that you're in bed. Relaxation therapy kind of falls under that also. And the interesting thing about cognitive behavioral therapy is both short-term and long-term effects definitely are borne out time after time on studies, and it's more effective than medication, okay? Really addressing this. The issue with it is almost no one gets cognitive behavioral therapy, formal cognitive behavioral therapy, because some of the limitations are, really it's psychotherapy, okay? So obviously it's truly and best done by a trained psychologist who really knows what they're doing when they're doing this. And they're dedicated sessions, usually conducted over a series of many weeks, potentially months, where it's 4 to 8 sessions most typically. Can be done individually or in groups, okay, and efficacy has been shown for both of those, as well as some digital formats where people sign in. As with many things, obviously, it all ties back to how invested is this person in really trying this and really engaging in the recommendations. But, definitely you can see as many as 60 to 70% of people respond to this quite significantly in terms of their insomnia, and more long-term, over more than a year, even approximately 45-50% can have sustained benefit. And a lot of that, of course, ties in with how much they're continuing to engage in it. So with the cognitive therapy and addressing those beliefs and attitudes that are working against you, some of the examples are, people will say, and you can understand, where they would think this and they would get these ideas and form these ideas that are working against them. But because they may have tried some things or they've dealt with it for years, they may come in and say, well, there's just really no hope. I've dealt with this long, or at my age, it's just not going to change. Those kind of things, nothing I can do. Nothing has an impact. Mom and dad had it, or mom had severe insomnia, so I guess I'm in the same boat. I'll be the same way. Or it can be if they've been treated with medication. No, I cannot sleep without medication X. It's not going to happen. So the goal of cognitive therapy is to talk with people and specifically tackle those beliefs head on and say, these ideas, they're not necessarily true. We can tackle this head on and, change how you think about this, and it can really make you much more open to improving your sleep substantially. And it can really decrease worry about lost sleep, so people can feel like, well, gosh, no matter what I do, I'm going to have this lost sleep, and there's just no way I'm ever going to be fully functional. There's a particular type of cognitive therapy that works for some people called paradoxical intention. And that's where they go to bed at a normal bedtime, but kind of contrary to what they might expect, they're instructed to try to stay awake when they lie down. So you say, when you lie down and try to go to sleep at night, I want you to lie there and stay awake. I want you to try to not go to sleep. And what that does is, on a subconscious level, it kind of gives them permission to kind of let go of a lot of that worry about lost sleep. So instead of sitting there thinking, oh, I'm not sleeping, then you're thinking, well, I'm not trying to sleep. I'm trying to stay awake. So then you can let kind of those normal homeostatic and circadian rhythm driving factors, that process S and process C, kind of have their effect and take effect and help facilitate sleep onset. Again, not a magic bullet or surefire fix, but it can be a tactic to help kind of decrease that self-imposed worry about insomnia and sleep. Acceptance and commitment therapy is a form of psychotherapy that you can use for insomnia. And that's where you try and teach the individual the importance of accepting their particular situation or life circumstances. Kind of staying in the present and in the moment, you know. And whatever thoughts or feelings they're having, to not try to reject those, to be more accepting of it, and avoid trying to change that. So that can be helpful for a lot of individuals, okay, that sort of acceptance. Tying in with that, and often, you know, used along with it, you can use some of the behavioral therapies like relaxation techniques like we talked about earlier. I like to do a combination of the progressive muscle relaxation and the breathing exercises. They can do other breathing exercises at other times, and certainly different types, okay? Meditation can be helpful for some individuals. And then guided imagery. Some people will use certain apps for guided imagery. Some people will actually have their spouse or bed partner kind of do this for them. And this is that kind of, you know, where it's, you know, close your eyes. You're on a quiet beach. You're walking along. You know, you see an interesting seashell and you pick it up. That's the kind of thing. And it really, it may sound silly, you know, but it actually can really help a lot of people. Again, very distracting from your worries and your thoughts and things like that, and can really be quite helpful. Sleep restriction, especially for individuals who are spending far too long in bed, can be quite helpful. And this is where you're limiting the amount of time that they're actually in there, and you're restricting it to less than what the goal is, okay? So commonly it can be 6 hours, at least 5 hours. We allow for at least 5 hours, but a lot of times we start off around 6, depending upon what their particular sleep schedule is. But you find out what specifically they feel they're sleeping. If they say, well, I'm lying in bed for 8 hours, but I'm only sleeping 6.5, then you're going to try and restrict that down to 6.5 to start with, okay? And in order to adjust that, you keep the same scheduled wake time, okay? And because usually that's the one that's the least flexible in terms of being able to adjust it. But you adjust the bedtime, okay? And you delay that in order to restrict. So, if they get up at 6 a.m. and they say, I feel like I sleep 6.5 hours, then you're going to have them go to bed at 11:30, okay? That's where you're going to start off from. And what you're doing is you're trying to enhance that sleep drive, that intrinsic sleep drive, and consolidate their sleep, okay? And what do I mean by that? What I mean by that is instead of, whatever amount of sleep they're getting, instead of spreading it out over 8 hours, for example, you're saying, okay, well, if you're only sleeping 6.5 hours, then you're only going to be in bed for 6.5 hours right now. So that way the percentage of time that they're asleep when they're in bed is much, much higher, okay? So it not only improves how long it takes them to fall asleep, but it can also improve staying asleep, okay? Because again, it increases that homeostatic drive for sleep. Some of the other directions you have to give them for sure are no napping, and you have to say, when you start this, you're going to be sleepy. You're going to be fatigued. Okay? So expect that. That's part of this. And then you reassess weekly. They do their sleep logs and diaries. And then when you see what that shows, if their sleep efficiency is greater than 90%, then you change that bedtime, moving it earlier incrementally, okay? Typically by 15 minutes. Can do it by 30, but I think kind of the slower you go, the better results you have. So instead of, like with our example, with the wake-up time at 6 a.m. and they're going to bed at 11:30, then if you look at their logs and they're sleeping more than 90%, then that's when you say, okay, instead of 11:30, we're going to do 11:15. Do that over the next week. And then you take another look. If that sleep efficiency is less than 85%, then you do the opposite. Okay? So then you'd, with our example, instead of 11:30, it'd be 11:45. Okay? And you just continue doing that until you reach an adequate amount of sleep where they feel good with what they're doing. Okay? Stimulus control is often very effective, especially used in conjunction with the others, and that's attempting to associate the bed and bedroom only with intimacy or sleep. Okay? And what you're doing is imprinting in your mind that that's the only acceptable kind of parameters for being in bed. So you go to bed only when you're sleepy. If you're unable to sleep, don't lie there in bed for prolonged periods and struggle. Get up, go to a different room, turn on low lamp level type lighting, read, again, not maybe some great novel that you really want to finish, but magazine level type reading, where you can read a few pages and it's maybe okay but not great. And then that way when you start noticing you're getting sleepy again, then go back to bed. And if that doesn't work or you experience that again later, get up, do the same thing. Okay? Definitely you want to encourage them to make sure they avoid clock watching. Okay? That's always important. And maintain that same normal wake-up time in the mornings, okay? And again, no napping, no daytime napping. That's important. Obviously with anyone who has any form of insomnia, if they say, well, I'm napping for 1 to 2 hours a day, that's kind of one of the first things you need to say, okay, well, we definitely need to cut this out because that's decreases your sleep drive. Probably not going to sleep well at night if you're taking the gas out of the tank in terms of that buildup of adenosine and sleepiness during the day, right? So very important. And then, of course, there are many medications that we use for insomnia. Especially more in the past, 10 years, 15 years, we've tried to move away from going to that as quickly, certainly, okay? They can have unwanted or undesired effects. The non-benzodiazepine sedative hypnotics, your Z drugs like zolpidem, zaleplon, and zopiclone, that's Ambien, Sonata, and Lunesta. While they can be effective, you really only want to use it in the short term. If you have to use it for whatever reason, because the psychological dependence can certainly develop where people feel like, no, I cannot sleep unless I'm on this. It can lead to obviously sedation during the daytime, holdover sedation. It can cause dizziness during the night, and almost any of these can increase risk for things like falls. So, and insomnia is more common as we age, so you're talking about an older patient population, so you want to be very careful with using medications that increase the propensity for a fall, because if you get up during the night, what happens? There's not as much light on, right? Or maybe no lights on. That increases your risk for falls. As we age, we get an age-related decline in our natural sense of balance, our vestibular sense. So that contributes to falls. And then if you add a medication that also can cause sedation and increased fall risk, not a great scenario. So that's, those are a big part of the reasons why we've tried to decrease the usage of this. And if we do use it, try to use lower dosages, okay? Melatonin can be beneficial, especially in terms of timing of sleep. If you there's a very specific phase response curve to melatonin. So if people have delayed sleep phase and they tend to fall asleep later in the night, you try to not give the melatonin close to bedtime. You try to give it more at that peak in terms of the phase response, in terms of advancing sleep, which is more like 7:30 to 8, maybe 8:15, 8:30, because that will advance their sleep far more rather than going to bed right at, taking the medication right at the time they go to bed, okay? We also have the melatonin receptor agonists, Ramelteon and Tazamelteon, can also be quite effective for conditions like non-24, especially in individuals with blindness. A lot of the medications can be used for sedation effect that are antidepressants, including trazodone. That's been used quite extensively over quite a few years now. Mirtazapine also has a significant sedating effect, and amitriptyline or Elavil has also been used. Other supplements like valerian. The benzodiazepines, of course, are extremely sedating, very effective for causing sleepiness, but you definitely get into more of those other potential side effects, like cognitive effects. As I mentioned earlier, I think it can even mimic dementia, so you need to be aware of that. Definitely increases fall risks, so you definitely can get into issues with that, especially there are quite varying half-lives, like temazepam, and then clonazepam, which has a very long half-life, like 30 hours. So, and then there's the histamine receptor antagonists, like diphenhydramine or doxepin. In more recent years, the orexin or hypocretin receptor antagonists, suvorexant, limborexant, and daridorexant. And the reason these two last classes that I mentioned, antagonists, work, the histaminergic system and the orexin neurosystem, those are both wake-promoting neural pathways, okay? So by antagonizing those receptors, then you help facilitate sleep, okay? And then antipsychotics, I don't, go to these certainly really unless there's something coexisting like bipolar disorder, schizophrenia, and I mean that's when they're already on it. So you may make recommendations in terms of timing or things like that. So there are many medicines that can help contribute to insomnia, or substances that can. Prednisone is notorious for causing insomnia, along with other things, the prednisone rage or irritability. Beta blockers can significantly cause insomnia. Also, it can increase dreaming, potentially nightmares as well. Beta blockers can. Dopamine agonists, as we talked about earlier, about 10% of people on dopamine agonists can develop quite significant insomnia. Stimulants, of course, during the day can have lingering effects, especially when they take them and what dosage. Definitely see a lot of people where they're on a stimulant medication and that effect appears to start lingering into the night and causing issues with insomnia. And of course alcohol, as I mentioned earlier. And then just one last thing quickly, just always remember that insomnia is not an island unto itself. Many things can present as insomnia. Can be untreated sleep apnea, undertreated sleep apnea. Same thing with restless legs or periodic limb movements. Their circadian rhythm disorders commonly present with the chief complaint of insomnia. Can't sleep at night. Well, it's really the timing of their sleep and that mismatch between the rest of the world and what our schedules are and the individual who has a circadian disorder. And pain conditions certainly interrupt sleep and can do that. And psychiatric conditions, individuals with bipolar disorder, if they're manic or hypomanic, then they sometimes may not sleep for several days during those acute episodes. And that's, just scratching the surface, in terms of other conditions. All right, I think I'm close to out of time. Does anyone have any questions here for the last minute? Yes, sir. Yeah, it can be, absolutely, for certain individuals, but as you can see, based off time, I knew I had to limit. But there are a lot of other adjunctive therapies and some digital strategies and materials that can be used that we're finding more and more may help some individuals. But yes, the question was, I didn't mention things like sound machines and things like that. Yes, absolutely, they can be effective for some individuals, but just had to kind of limit how much I covered in 1 hour, sorry.
Thank you so much,
you.
Dr. Tallent. We appreciate it.